Good evening and welcome to 1st December Journal Journey. I know everyone is in vacation mode, but we have to keep our promise. Today is AIDS Awareness Day. It was a dreaded disease in 1980s, and we have witnessed that. But slowly and steadily, science has won over the viruses. And now it is controllable like COVID-19. Let us stick to the science for betterment of life. And in our journal journey, we always take current and emerging issues which are helpful for practicing pediatricians. And today we are blessed with so many stalwarts who have joined. I welcome past President Dr. Pramod Wankhede as moderator for further proceedings. Dr. Wankhede, please.
Thank you very much, madam. Thanks a lot. The outset, I just welcome our all dignitaries, our guests, honorable guests, experts, and viewers who has joined on Zoom and our YouTube live. So welcome you all. Madam, first of all, our journey will be completing 2 years now. It has started from the 1st July 1921, and relentlessly it is going on and on. Of course, MAHAAP has taken a major part of it now, and they are also contributing to continue it. Thank you, MAHAAP, President and Secretary also. Now, I invite our dynamic personality, dynamic lady, Dr. Neha Singh, who is a co-chairperson of Women's Wing, MAHAAP. Dr. Neha, madam, please.
Thank you, sir. Good evening, everyone. I welcome all the respected dignitaries from Central IIT, MAHAAP, my seniors and friends from Raigad IIT and other branches who have joined us through Zoom as well as YouTube Live. I welcome MAHAAP President Dr. Ramakant Patil sir, Secretary General Dr. Amol Pawar sir. I'm extremely delighted to welcome our guest of honor, none other than our Central IIP President-elect Dr. G.V. Basavaraj sir. I also welcome our guest of honor, MAHAAP President-elect Dr. Ram Gopal Chiraja sir for today's journal journey. I welcome Dr. Jitendra Gawane sir from Central IIP, and I welcome Raigad IIP President Vikas More sir and Dr. Ajay Kohli sir and Chitra Kulkarni ma'am, also Dr. Pramod Wankhede sir. I also welcome the esteemed experts of today, Dr. Niman Mohanty sir and Dr. Atish Wakhane sir, presenters Dr. Prasanna Bansori sir and Dr. Priyanka. Now I hand over to our President sir, MAHAAP President sir, Dr. Ramakant Patil sir. Kindly give your blessing, sir.
Thank you, Neha. I can't agree more with Pramod Wankhede sir, the most dynamic vice chairperson of our Women's Committee, Neha, who is persistently a backbone for many programs of MAHAAP on virtual programs. We have got again the chance of having Dr. Basavaraja as our chief guest, and our incoming MAHAAP President, Dr. Ram Gopal, as a guest of honor. What is perseverance, what is persistence, is Raigad IIP has depicted how the perseverance and persistence is there. And accolades, bouquet, and real appreciation for Dr. Chitra Kulkarni madam, who is persistently following this journal journey, which has been started by Raigad IIP under aegis of Dr. Hemant Gangolia, and very strongly supported by Dr. Niman Mohanty sir in thick and thin of his health also. Even when he was admitted, he had joined for journal journey And this shows how hardcore teacher he is and how he likes to be on teaching session. We really have got privilege to have our dynamic CIP EB colleague, Dr. Jitendra Gawane sir. We look him up a future president of CIP down the line in coming 10 years. And also equally dynamic, our Secretary General, Dr. Amol Pawar. In my tenure, this might be the last journal journey, but as a president, because I am very eager to join this journal journey, and I like the brickbats at the end. And sometimes they are uncalled for comments, but those are my genuine curiosities and difficulties, and I like to chip in and ask my questions also. We have got wonderful presenters today, and along with Dr. Nimen Mohanty sir, we have got one more expert, a young hemato-oncologist, a dynamic one, Dr. Atish. And we all know about, because now for us it was only induction, consolidation, and maintenance. Now these BCL, APL, MRD, and all those things, these people are, we have to get at least acquainted with this jargon. And probably this is the reason that Priyanka has chosen these PFM based protocols for acute lymphoblastic leukemia. And for NAFLD, we adults are more worried about this NAFLD. Not only NAFLD, but AFLD also. But NAFLD is like getting an innocent cirrhosis. And how we could approach that. And Prasanna is going to elucidate on that, about this NAFLD. Very well chosen topics. I wish all the best for incoming president and secretary. We are again privileged to have Amol Pawar as a secretary for another 2 years. And Ram Gopal will be the president in 2024. I welcome him, and we know when the battle is handed over to him, he is definitely going to do the justice for that. And we know every year the bar is being raised. He will again raise the bar further. And again, it will be for the Nagpur president to raise the bar further. So I thank you, Dr. Wankhede sir, for giving an opportunity to have interaction with all the delegates. And success of this program is wonderful. People are definitely academically oriented. 96 already delegates are there on this. And many times even people join on YouTube also once this 100 members. And we were happy and lucky enough to join the Raigad IIP's initiative of this journal journey. It had given one more feather in our cap of Maha IIP, that journal journey, and it was one more program. And all the programs are extremely well handled. And I again once more I express my thanks and appreciate and kudos and bouquets to Dr. Chitra Kulkarni and Nimen Mohanty sir. With this few words, I hand it back over to Neha. And in January session, I will be joining as a common member, foot soldier of IIP. Over to you, Neha.
Thank you so much, sir. You are most invited in all the journeys of our journal journey. And now I request Secretary General, Maha IIP Secretary General, Dr. Amol Pawar sir, to welcome and give his blessings.
Thank you, Neha, for your kind words. First of all, I welcome all the experts, dignitaries, then all the viewers, PG students who are present on Zoom and YouTube platform also to this journal journey session of December month. I also welcome chief guest, Dr. GV Basavaraja sir, who has joined from Pune. He is attending Pedicriticon in Pune, and also guest of honor, Dr. Ram Gopal Chezara sir, who is president-elect right now and president of Maharashtra IIP 2024. This journal journey, it started 2.5 years under the helm of Dr. Gangulia sir and Dr. Jay Bhandarkar sir, and it was very well supported by all the Raigad IIP members, including Chitra Kulkarni ma'am, and all the various articles, interesting articles in all these things. Subspecialties were chosen by Dr. Nimen Mohanty sir. And firstly, for first 6-7 months, it was for Raigad IIP. The presenters were from nearby Mumbai. Then once Dr. Hemant Gangulia took over, then we started it for Maharashtra, and various branches across Maharashtra, they have given the presidents and secretaries have given the interesting presenter, means the interested presenters for this journal journey, and it almost 30 months this session is there, and it will be continued next year. Hope so. Dr. Ram sir will agree with the team, and then again Raigada IIP will be the hosting branch, and we can take it over at national level also with the help of Dr. G.V. Basavaraja sir. So without wasting time, I thank Neha also for introducing me, and Dr. G.V. Basavaraja sir is the chief guest. Sir, are you there?
Yes, yes.
Okay.
Yes, sir is
Dr.
there.
G.V. Basavaraja
Because
sir.
of network issue.
Okay. Sir,
Sir,
you can
please
speak
give your
right now, sir.
blessings.
Please give blessings.
Yeah, over. There is a network issue. Really, I am appreciate the work leadership of Dr. Ramakant Patil, our dynamic president. He was also happens to be executive board member. He's seen his acumen, administrative capability, and the work which has been done for the central IAP, along with our Maharashtra IAP dynamic secretary, Dr. Amul Pawar. And really, I appreciate the team up in Raigad. Really, they have done a great job, especially Dr. Jayant Bhandarkar, Chitra Kulkarni Madam, Pramod Wankade, and really they all did a great job during my tenure as an honorary secretary also. I was closely watching. So the academic work, which has been a benchmark of a MahaAP in the last 4 to 5 years, what I see, especially journal journey is one of the things which is hitting the minds of the young pediatrician, and also it helping the clinicians to start thinking about and critically how we need to manage what is really the new things which is emerging. In this regard, this journal journey is really making a big change. In most of the other branches is also started adopting this. Even Central IAP is also started that once in 15 days. Really hats up to the work done by the MahaAP under the Dr. Ramakant Patil, Dr. Amul Pawar, and our incoming president of MahaAP, Dr. Ram Gopal Chejra, is equally is not only the great organizational man, he can take the academics to the greater height. Wish you all the best for the team for doing this great academic work. Really, I am honored to be here. Since I am in Pune, where the network is the issue, sorry if I am not able to stay for a longer period of time. Thank you very much, Dr. Ramakant Patil and Dr. Amul Pawar. Thank you.
Thank you, sir.
Thank you, sir.
Thank you for your time and blessings.
Neha, please continue.
Thank you, sir.
Thank
Thank
you,
you for
sir.
your kindness.
Now I welcome Dr. Ram Gopal Chejra sir, who is MahaAP President-elect. He is also medico-legal consultant expert. So I now ask him for the blessings. Over to you, sir.
Thank you, Neha madam. Good evening, everyone. And thank you, Basavaraja sir and Ramakant Patil sir, for showing the confidence. 2-3 things before I start. I have already discussed with the Amol in the evening that we want to make this Zoom platform for more people. So from next January onwards, we will have at least subscription of 300 to 500 people. 100 is very less, and every time we get this problem. Secondly, the scientific program, yes, there would be a lot of changes in the scientific program. But I promise Mohanty sir, this journal journey will continue in the next tenure. Since this program I like and I try to watch it live also, but sometimes I see on the YouTube and it reminds me my JJ days. So definitely we will continue this program. I will not take much time. We are already late. Let us start the program. And over to Neha madam.
Thank you so much, sir. Now I hand over to Dr. Pramod Wankade sir for the further proceeding. Over to you, sir.
Thank you, madam. Thank you, madam. Now I invite our President, IAP Raigad, Dr. Vikas More, to welcome the guest.
Thank you so much, Venkateswar sir. At the outset, on the behalf of IIP Raigad, I am so humbled to see such a dignitaries who have joined for today's evening. First of all, Dr. G.V. Basavaraja sir, Dr. Ram Gopal Chhajera sir, Dr. Ramakant Patil sir, Dr. Amol Pawar, my ideal Dr. Jitendra Gavani, and expert respected Dr. Niman Mohanty sir, Dr. Atish Bhakne, and presenter gem of IIP Raigad, Dr. Prasanna Bansode, and Dr. Priyanka Pawar from Nagpur. So this is a very beautiful evening for an academic purpose. This is a Journal Journey is a gem which we keep close to our heart, and MAHA-IIP is so generous that they have continued this activity for longer period, and I'm so much thankful to Ram Gopal Chhajera sir that he also consented that this journey will continue, and we assure you that we will do our best to give the best academic program in coming 1 year under your leadership. We have seen your organization skills, and we want to work under you like this only. And lastly, I want to just make a small announcement that IIP Raigad is going to organize State Maha Neocon Conference next year in month of June. So everybody, we haven't formally announced. This is the first formal announcement on a large scale. So the things are going on, but we assure you that we will give you the best of academic feast in coming Maha Neocon Conference in month of June. Over to you, Venkateswar sir, for further proceedings.
Thank you, Vikas sir. Thank you very much. Now I take pleasure to invite our main pillar of this journal journey, Dr. Chitra ma'am, to introduce our first expert, Dr. Niman Mohanty sir, who is also guide and mentor for us, and presenter, Dr. Prasanna Bansode, the distinguished academician of Raigad IIP. Over to Chitra ma'am.
Yeah, our mentor and main brain behind Journal Journey is our expert today. Sir is Professor Emeritus and has been trained in PGI Chandigarh. We are fortunate to have him as an expert for first topic, which will be discussed by intensivist Dr. Prasanna Bansode sir. He is practicing pediatrician from Panvel, Khanda Colony. May I request Dr. Prasanna sir to start his presentation.
Are slides visible?
Yes, make it a
Yes,
full
sir.
screen.
Yes, sir.
Please make it full screen.
Is it okay now?
Yes,
Yeah.
sir.
Yes.
Yeah. So I'm very thankful to the IIP, Raigad IIP, for re-inviting me for the presentation of this topic in the Journal Journey. I am very delighted about it because I came across to the newer topic, which is I haven't studied so far. I am very thankful to Dr. Niman Mohanty sir for selecting such a topic, which needs great awareness in the general pediatricians, because this has got a really deleterious impact in the long run. So my first presentation is about NAFLD. NAFLD is a pediatric non-alcoholic fatty liver disease. So usually we have heard about the fatty liver disease in adulthood, but with the growing evidence, we are now seeing more and more cases of fatty liver disease in children. The incidence is rising. NAFLD, as the name suggests, there is a fat deposition in the liver. Wherever there is a fat deposition which is more than 5% into the liver, we call it as a hepatic steatosis. But to call it as a NAFLD, you need to have a chronic liver disease. Now, the most common chronic disease of the liver in childhood has been replaced by NAFLD. And before diagnosing NAFLD, we need to exclude any other causes of fat deposition in the liver, like metabolic disorders, sometimes some steatogenic drugs, sometimes viral hepatitis, and so on. The list is much more, but we need to rule out first other causes of hepatic steatosis. In nutshell, NAFLD is a diagnosis of exclusion. But with the NAFLD, we have to discuss about the obesity here, because obesity has got very strong association with the NAFLD. The association is so strong that almost 60% of the obese person, they may land up into the NAFLD. So we have to consider obesity as a major risk factor for development of NAFLD. The parallel rise of NAFLD with the rise of obesity depict that there is a strong association between them. Again, we have to discuss, or we have to consider, the metabolic syndrome as an association with the NAFLD. The metabolic syndrome is a syndrome where you get more clinical features of a different type, like hypertension, diabetes mellitus, dyslipidemia, hyperinsulinemia. Obesity is again one of the criteria of a metabolic syndrome. Why we need to see about metabolic syndromes? Because metabolic syndromes are the one which leads to the progression of the NAFLD to the severe form of NAFLD, which we call it as a NASH. Now the prevalence, by pooled prevalence for adult, is almost 38.6%. And prevalence among the non-obese and obese children, you can see the obese children has got a prevalence of almost 63.4%, which is very high. NASH has got a long form of non-alcoholic steatohepatitis. Now, name itself tells you that there is a hepatitis. That means there is not just a fat accumulation, but there is an inflammatory response started building up into the liver, and that inflammatory response is destroying to the liver and may progress to the cirrhosis or sometimes end-stage liver disease, which may require liver transplant later on. That is the reason this topic is very important to discuss just now. There is so many risk factors for development of NASH. Like if there is a pre-diabetic person with obesity, with NAFLD, then they have 30% chance that they will land up into severe histological disease. If the child develops fatty liver at a young age, then they have a portal pattern of fibrosis. And if the child has obstructive sleep apnea, then they have greater chance of developing fibrosis. Again, microbiota, a great topic for the research, and they have shown that there is a dysbiosis of microbiota, which is again a risk factor for developing severe fibrosis. Now coming to the real incidence prevalence of childhood obesity, because this is the friend of NAFLD. If we disconnect the friend from our liver, then we will be all right. The friend is very bad. Now, the childhood obesity in India, the study done from IGMC Nagpur in 2014 shown that this is from rural area they did, the overweight prevalence was 5.08. But the meta-analysis which is done in 2023 from India only, the overweight prevalence is almost 20.4, which is more than double in only 10 years span or 9 years. Obesity has risen up from 3.48% to 8.4%, again a double rise. So the rise is likely to get continued. The World Obesity Federation has declared that by the end of 2030, there may be 258 million obese children from the India. So again, worth to mention about a scale study, which is a study of liver diseases in a children as an epidemiological study, but the study is histologically proven NASH cases. Here they did a histological study from common population and they found it out that the prevalence is almost 9.6%. But look at the prevalence from the obese patients. It's almost to the tune of 30%. And from these patients, almost 20 to 50% of them are likely to develop NASH, which is a very, very problematic condition. This is the study which is done by Dr. Anupam Sibal from Apollo Indraprasth, which is done in 2017 from the urban area of Haryana. So they have selected affluent schools. And here you can see that the mild and moderate cases of hepatic depositions they have found out. The association of obesity has almost 37%. And there is almost 8.1% cases has got association of metabolic syndrome with this obesity. So these 8.1% are likely to land up in a irreversible cirrhosis or development of NASH. That is why we are really concerned about this. We are most of the time are aware about the silent killers in our pediatric practice and in our medicine practice, like diabetes mellitus, hyperthyroidism, immunodeficiency syndromes, untreatable or drug-resistant tuberculosis, cancers. But we are yet not aware about NAFLD, which is very, very slowly progressive. And the problem is that they do not have any clinical presentations. And even if a doctor says to the parents about the obesity and the presence of NAFLD, the parents find that child is okay, there is no problem with it. But they don't understand, at least we should understand that they may land up in a problem. So this is the awareness. I think this is an awareness presentation for all the general pediatricians about the NAFLD. This is again from the same study done by Anupam Sibal. They showed that 36.9% rate of NAFLD in their studies from the Indian populations. This is a very interesting study done by Clinical Molecular Hepatology in 2020. See the forecasted prevalence of NAFLD they have forecasted. From 1990, 18.2%, and this is a systematic review. Almost how many lakhs? 24 lakh patients they have reviewed. 18.2% to 55.7%. So this is the first forecasted number. So this much of burden is going to go to the hepatology, and this will create a tremendous burden economically, morbidity wise, and mortality wise. And one more thing to see that the region from where these patients are likely to be going. Here the Asia comes to about 62.5%. So in the recent article from the Times of India, I have read that more than 20% of the obese people from the world will be from India in the next future. So we need to act early. Here is again one study which is done in August 2020 by eClinical Medicine. They did a Kaplan-Meier survival analysis of the NASH and NAFLD patients. So here you can see the chances of all-cause mortality or liver transplant. That means these patients are landing up into either mortality or landing up into liver transplant. The upper graph shows cases of hepatocellular carcinoma, almost 50%. We are not aware of hepatocellular, or we don't consider hepatocellular carcinoma as a case in a pediatric population, but very few cases are still being reported at 7 years of age, at 8 years of age of developed hepatocellular carcinoma. So we still think that these kind of cases may still get rise. So this study tells us about the seriousness of these problems. This slide tells you about the simple pathogenesis of the NAFLD. There is a healthy liver, but when the tissue capacity to accept subcutaneous tissue capacity to accept the adipocyte, excess adipocyte get exceeded, then the tissue get deposited, adipocyte get deposited into the muscle and the extra subcutaneous areas. Then they get deposited into the liver. From liver, they accumulate the space in the liver. And the heart of the problem is they develop insulin resistance. And because of insulin resistance, the next slide will tell you, because of insulin resistance, there will be lysis of the fat which is deposited in the muscles and other subcutaneous areas. And this will release a large amount of free fatty acids, which get deposited into the liver in the form of triglycerides. But liver also has got some capacity. They can't balloon too much. So the extra amount of fat which get accumulated into the liver start releasing adipokines, just like a cytokines. And when the liver accommodate the fat, that is the first hit to the liver. And the second hit start when the excess fat start releasing adipokines, and the adipokines start damaging the liver by inviting other cytokines, all inflammatory cells and Kupffer cells to the site of inflammation and start damaging the liver and liver cells. This second hit has been considered to be important, but growing body of evidence suggests that there are multiple hits to the liver, like gut microbiota. Insulin resistance is the first factor, but also has got glucagon resistance, which continues to have glycogenolysis but difficult amino acid synthesis. The liver lose his capacity or lose his balance of autophagy. Autophagy means where the liver itself can handle his dead tissues and secrete them into the circulation and use the dead particle for itself recovery. Use the dead particles for the recovery of the tissue. But because of this condition, liver loses this capacity of autophagy. And that is the reason liver start getting damaged, getting fibrous, and led up into NASH. These atherogenic dyslipidemia, type 2 diabetes, hypertension, and central obesity are the metabolic syndrome are associated with these conditions. They are really worsens the condition of the liver once the fat start depositing into the liver. So this is the pathogenesis. Ideally speaking, the pathogenesis is yet not completely understood. There are still research going on what exactly the problem that happening into the liver. These are the just recent publications which we are going through. Now, here comes the role of pediatricians, because as we understood that this disease starts in a childhood and then develops slowly into the adulthood. Even a pediatric patients can also get a NASH. That is not a doubt. But as the disease itself is a chronic, so most of the patients are landing up into the NASH in adulthood or in adolescent age. So the pediatricians has to suspect this case first. Now, what to suspect and how to screen for these patients is a more important. So NASPGHAN has got some recommendations for our pediatrician to whom to screen. For whom to screen, they have selected a years, age, 9 to 11 years of age, a BMI with more than 95%. If you find any patient with BMI of 95%, needs to be screened for NAFLD. A BMI more than 86% but less than 94% is not fitting into the above category. But still, if he has got more than 86%, but with the risk factor is again a diabetes, hypertension, any metabolic syndrome association, any family history positive for liver disease, any sibling suffering from any liver disease, those need to be screened for NAFLD. Now the question is, what is the screening tool? Now they did most of the studies and found out that ALT is the best tool for the screening purposes. The screening tool has to be simple, cost effective, widely available, easy to do. That is why they have selected ALT as a best screening tool for these kind of people. What point ALT should be taken as an abnormal is the upper limit of a normal, which is age and gender appropriate. That has to be taken as an abnormal. Suppose the upper limit is considered to be 30, then the 2 times above that has to be considered it as an abnormal ALT. Then again, they tried to use ultrasonography as a screening tool, but ultrasonography has got a very poor sensitivity and poor specificity, but still ultrasound is useful not to the evaluation of NAFLD, but to rule out any other problem which is leading to the fat deposition or liver problem. Just like any mass, any cystic lesions, any biliary pathologies, those are being ruled out by doing ultrasonography. Here, ultrasonography is useful. CT scan, they found out to have high sensitivity, but non-availability and the cost, and most important is the exposure to the radiation. So this cannot be used as a screening tool. That is why CT has been discarded as a screening tool. Same with the MRI, having good accuracy, but the cost effectiveness, the availability, and still with MRI, there is no still quantifications or no still data to what to call it as a fat accumulation and what to call it as a severe or F1 fibrosis, F2 fibrosis, F3 fibrosis. That become difficult. So MRI has been ruled out as a screening tool. And during the evaluation, it is very important to rule out other reasons of fat depositions like viral infections, genetic problems, any metabolic disorders, autoimmune disorders, or any lipid issues in the patients, endocrinal issues. So all those differential diagnoses has to be ruled out before labeling the child as a NAFLD. As I said, NAFLD is a diagnosis of exclusion. Here is the flow chart which is presented by NASPGHAN. So when to worry? When there is persistent elevation of a ALT more than 3 months. That means for 3 months child has to be in the follow-up and do LFT after 3 months. If the LFTs are elevated, see to it there, are there any red flag signs? If there are any red flag signs like developing metabolic syndromes, developing any lipid abnormalities, developing any hypertension, jaundice, anything, refer to hepatologist for further evaluation. If there are no red flag signs, then find out what magnitude of ALT elevation it is. If the ALT is more than 80, then it is more significant. And persistent elevation of ALT more than 80 with a short period of interval, then we need to refer this child to the gastroenterologist or hepatologist because these patients are likely to develop NASH very rapidly. If the ALT is not above 80, no, then counsel on diet, try to modify his daily routine, try to stabilize him or try to counsel him, try to do all non-interventional modalities for the management of obesity related problems and repeat the liver chemistry in a short term 1 to 6 months. If the ALTs are above, again, upper limit, 2 times upper limit of a normal, refer him to the hepatologist for the further evaluation. If the ALTs are not raised above the twice the upper limit of a normal, then return to the standard care. If in all this follow-up, at any time the child develops signs and symptoms of a liver disease, he needs further testing. But if he doesn't develop any signs and symptoms of liver disease, they don't need any further testing, but still they need follow-up every 2 to 3 years because they may develop metabolic syndromes or may develop obesity in the later life. So we can't leave them alone. So at 2 or 3 years of age, again review the child for the developing obesity, hypertension, lipid disorders, diabetes, and then evaluate again for them. Once you did the evaluation, the gold standard for diagnosis of NAFLD, NASPGHAN has not recommended it liver biopsy as a gold standard, but still few review journals have said that liver biopsy is a gold standard. So whom to subject? Oh, sorry. Before going to liver biopsy, we can do transient elastography. Transient elastography is an ultrasound guided technique which is done to quantify the amount of fat which is deposited and sometimes to the degree of fibrosis child is developing. All studies have shown that there is 81 to 85% accuracy of the ultrasound for detecting the fat deposition and developing fibrosis. While MRI elastography has got some more sensitivity and specificity. Specificity is almost 85% and sensitivity is almost 88%. But that doesn't mean we should do elastography and MRI elastography every now and then. The principal biomarker to be followed is only ALT. Here comes, next is the liver biopsy. Now, who are the subjects where we need a liver biopsy? The subjects we need a liver biopsy, they should be at increased risk factor for NASH and fibrosis. That means they have some metabolic factors which are acting. They have a child family history, strong family history who has a developed NASH or worsening LFTs. They need liver biopsy. If ALT persistently elevated more than 80, they need liver biopsy. There is an alteration of a ratio of AST to ALT. If the child is developing splenomegaly, if there are more risk factors like diabetes mellitus and panhypopituitarism, these kind of children needs liver biopsy urgently. The problem with liver biopsy is that NAFLD is really a heterogeneous disease. That means the fat is not going to deposit homogeneously into the liver. The liver biopsy will take a tissue hardly 2 centimeters, a small amount from a specific area. So sometimes we miss that there may be problem, but the liver biopsy is not showing. So repeated liver biopsy sometimes are necessary, but convincing the relatives for repeated liver biopsy is a troublesome. But still liver biopsy is considered to be a gold standard for diagnosing NAFLD. I have shown some diagrams of histological from NAFLD and normal liver. Here we can see the normal liver. The whitish yellow spots are the fat deposition, which is more than 5% of the liver. And here you can see the NASH, the necrose and the damaged liver. Next, how do we manage? Ideally, once the job of pediatrician is to just suspect, do not miss this case, have a high index of suspicion, and whenever you find any alteration, refer him to the hepatologist. The management involves lifestyle mediated weight loss. That means they should have reduced excessive energy intake of sugary content, sweetened beverages, and all high energy foods. Why they need this? Because they stimulate the lipogenesis in your body. In fact, sucrose and fructose related beverages, they are more damaging, not only because of lipolysis, but they alter the gut microbiota, and there will be transmigration of the gut microbiota by the leaky gut, and they will again create an inflammatory response by leaking into the portal vein and then reaching into the liver and creating an inflammatory response into the liver. That is why this dieting management is very, very important. In fact, NASPGHAN and AASLA, they have suggested that more emphasis to be given to the dietic management, not and also to the exercise, but more emphasis to be given to the dietic management. Second important point is a physical activity. Moderate to intense exercise at least for 30 minutes is very important for these kind of children or the patients. Balanced diet has to be taken. That means with high fiber diet. But following this kind of schedule and changing alteration in their regular schedule is a very difficult task for them. So they need repeated counseling. They need repeated behavioral problems. They may get behavioral issues. And sometimes a behavior issue itself is the problem which leads to excessive consumption of these sugary content and leading to NAFLD. So behavioral management and psychotherapy also stand some importance in the management of NAFLD. Lifestyle approach like regular meals, not skipping meals, staying hydrated only with the water and plenty of water, maintaining proper sleep hygiene. Again, sleep hygiene has got some association with NAFLD, and stress reduction is important. Next, therapy. Now, we pediatricians has got nothing to do much in this therapy area, but from the what I read is the vitamin E has been recommended by the NASPGHAN, which has been proven by the TONIC trial, where they use 400 international units of natural form of vitamin E 2 times a day for few months to years. And they have found out that there is a greater resolution of histological features of NASH. But again, the caveat they have mentioned that though they don't have a data of long-term use of vitamin E, because these children can land up into cardiovascular problems later on. So this is just a recommendations by them, and they don't have a clear-cut proof that this is a really wonderful drug. Now the future therapies are multiple drugs are being in a pipeline are getting developed for the management of NASH. One of them is biotiquolic acid, which is pinotiquolic acid, which is used. Histamine bititrate delayed release tablet, ribavirin. So many drugs are in the pipelines. Here is the slide which tells some of them. If there is NAFLD, a lifestyle modification, probiotic, omega-3 fatty acids, and high dose of metformin. But neither NASPGHAN nor AASLA suggest the use of metformin in the management of NAFLD. When the patient develops NASH, vitamin E, I have already told you, elafibranor has been used, obeticholic acid are being tried, but not in a pediatric population. These studies are yet in a clinical trials. Cerny rock, selenoseratives, combination therapy are tried for fibrosis. All these are studies in a clinical trial. Almost 200 clinical trials are going on. Only 20 clinical trials in a pediatric patient. So in the future, again, we may not get a convincing clinical data from the these liver bodies for use in pediatric patients. So we may at the helm of some issues for the management of NAFLD, but as a general pediatrician, we should not worry about this. Our main aim is to find out these children early, suspect early, investigate early, and follow the screening protocol recommended by the NASPGHAN. My message is the early identification of high-risk patient is important. Follow-up and timely referral to the hepatologist is very important. The management of NAFLD really requires a multidisciplinary approach. That means we don't have any role to play here. What are the needs? The need is more clinical studies in a pediatric age groups. That is the real need. There is a real need of more non-invasive diagnostic and prognostics too, because sonography, MRI are yet developing few newer criteria for diagnosing and quantifying the amount of fat deposited or the stages of fibrosis. And third most important thing which is needed is the more specific biomarker of this disease, which is yet to be developed. Thank you for patience hearing. I am done, sir. Thank you.
Thank you. Please stop sharing.
Where to stop it, madam?
You have to stop share from your screen. Mohanty sir, your comments.
Ma'am, I'll do that.
Mohanty sir, your comments.
Okay. Thank you, Dr. Prasanna. He has meticulously done this topic very well. So I need not elaborate much. But what I wanted to start from the last words Dr. Prasanna had said, that more studies are required. And in that process, local studies, in the local population, what is happening, that is much more important. Dr. Chitra had started a little small initiative that we requested all our pediatrician friends in Raigad district from their clinic, if they can collaborate, and certain selected OBs or overweight children, if you can study, it will be a very nice pool of data we can generate from the locality.
Yeah.
It is going on. It is going on, sir.
We can, So you can do it towards its NFLD also. The aspect has to be identified. So this NFLD, non-alcoholic, actually it's not that the children use alcohol, but normally the steatosis and fibrosis are seen by the histopathologists in the adult area normally. And mostly it is because of alcohol. So they said there are alcoholic causes and there are non-alcoholic causes. From that, they have extrapolated those words to children. It is not correct. So now the new term has come, MASLD, metabolic dysfunction associated steatotic liver disease, to replace NFLD. Coming to obesity, as Dr. Prasanna has already stressed, and we should, in a mass movement, we should sensitize our population that obesity is one of the major epidemics of 21st century. Clinical spectrum of liver abnormalities, if associated with obesity, if there is obesity and if there is some indicator that there is a liver abnormality there in the form of liver enlargement or nigricans is present in this, or he has this splenomegaly, those cases have to be investigated to rule out any kind of chronic liver disease like this NFLD. So start with there is accumulation of fat, as Dr. Prasanna had said, in the hepatic parenchyma, and the fat globules, actually the triglyceride globules, they go intracellular and displace the nucleus to a periphery. In a histopathology, if you see, Dr. Prasanna had shown this, the nucleus is shifted to the periphery and it compressed with the fat globule. And there, if this is the scenario, it is called hepatic steatosis only. And if it's concomitant with necroinflammation, that is with features of inflammation in form of CRP, rare CRP, or there is a fibrosis, then we can call it as a NASH. Then coming to the obesity, besides obesity, there are other diseases. Dr. Prasanna has said, when you are finding such a scenario, you should also look for the other causes of NASH, which also includes Wilson disease, dyslipidemia, diabetic lipoproteinemia. Even in acute PM, we can see such scenario, fatty liver. Drugs like steroids, INH, amiodarone, estrogen, these also causes this. So in the history, if such drugs are there, so we have to rule out and advise the parents accordingly. What we do not have autopsy studies for children, but autopsy studies are done in the adults in the literature is showing about 20% to 25% are having this autopsy study found that the NASH or NAFLD is there. High ALT in adolescents, only without any liver disease, is only 1.5% high ALT there in normal adolescents. But with overweight, it becomes 5%, and its obesity becomes 9.5%. And in US, see, in the age group of 2 to 4-year-old children, they have high ALT in 0.7%, which reaches 17%, 3% by the age of 15 to 19 years. See how dangerous it is now. So we must rule out these conditions clinically, which indicator we must go in for that. So the pathophysiology, Dr. Saab has shown very good pictures that what is the first hit, what is the second hit. Second hit means there is a presence of oxidative stress, lipid peroxidation, decreased glutathione and ATP, and plus if there is a genetic predisposition, that the second hits drives these patients to the NASH. And how the screening has to be done, he has already told us that if the ALT is raised more than 2 times of the upper limit of normal to more than 5%, he has shown 2 scenarios. We label this child as NAFLD, and further investigation are done. And if in the NAFLD only, if the 5% of acanthosis nigricans, you find them having NASH. This is a clinical observation study. In the ultrasound, elastography, he has already pointed out. See, ultrasound also, it is discarded in Western countries, but we do not have the advanced gadgets like elastography. So we are heavily dependent on the ultrasound. And for that, many of our own friends do themselves the ultrasound they do. And the fatty liver is really, it is easy. If one trained hand is there, you can detect fatty liver in the, it's a screening, first screening test. And you can, before going for the further investigation, like biopsy and all, ultrasound is a very good, modality. We grade even this fatty liver to grade 1 when this image is only granular appearance. We call it a grade 2 fatty liver when it is contrasted with the vessels are prominent with the contrast of this granular picture, the grade 2 fatty liver. And if the fully obscure picture, it is called a grade 3. Vessels are not even seen. So the management, Dr. Saab has already said. I will say only 2 lines that weight and lifestyle management is very important. Physical activity, it increases the insulin sensitivity. To treat the underlying disease is most important. If, as I said, the ALT is raised more than 3 months, So Sheila Sherlock book says if 3 months radiality means it goes a chronic liver disease in a child, we go for detailed investigation. Unlike adult, they take 6 months. Here, vitamin E versus metformin, there has been more trials in which metformin did not produce any very good results. So metformin is out so far as fatty liver disease is concerned, although metformin is used for obesity for adults. No benefit with UDCA, clofibret, betaine on N-acetylcysteine. So that's the my comments. I almost summarized whatever Dr. Saab has presented. He has presented so well. I have nothing more to add. Thank you.
Sorry to forget the differential diagnosis slide, sir.
Yes, sir. We can share it later on. Now we have to move to second topic.
Thank you, sir. Thank you very much. Now I request our president, IIP Raigad President, Dr. Vikas More, to introduce our second expert, Dr. Bakane, and a presenter, Dr. Priyanka Pawar.
Dr. Vikas is having some emergency. So please let me introduce with your permission.
Yeah.
Dr. Atish Narayan Rao Bakane sir is a hemato-oncologist and he is graduate from prestigious KEM hospital. He has trained for bone marrow transplant in Europe for many years and he was ex-consultant of Indraprastha Apollo Hospital, Delhi. Presently, he is working in BMT Center, Ray of Hope in Nagpur. Our presenter, Dr. Priyanka Pawar, has been graduated from Government Medical College, Akola, my hometown, and has studied MBBS and DCH later on in Lata Mangeshkar, Nagpur. She is having her own setup in Nagpur and also working as clinical associate in National Cancer Institute, Nagpur. Over to you, Dr. Priyanka, for your presentation.
Thank you, ma'am. I thank you, Maha IIP, for giving me this opportunity to present here on such a big platform.
Please share your
Is the
slides.
screen visible, sir?
No, not yet.
Ma'am, you first open the presentation, make it minimize, and then click on the share screen button.
Yes.
Yes, ma'am. Presentation is visible. Make it full screen, please. Thank you.
Yeah.
Yes.
So today's topic is about Pediatric Hemato-Oncology Journal, treatment of newly based pediatric ALL on BFM-based chemotherapy protocol, its feasibility and outcome at a tertiary care center in India, BLK Max Super Specialty Hospital, Delhi. Brief introduction about ALL. It is the most common childhood cancers. It accounts for 25% of childhood cancers, 75% of childhood leukemias. The incident rate is 1.38 per 1 lakh population. Peak incidence is in between 2 to 5 years of age, predominantly seen in males. ALL is a malignancy of B or T lymphoblasts characterized by uncontrolled proliferation of abnormal immature lymphocytes and their progenitors, which ultimately leads to replacement of bone marrow elements and other lymphoid organs, resulting in a typical disease pattern characteristic of ALL. There are two basic types of ALL, pre-BALL and TALL. Looking at the clinical features of ALL, there is anorexia, fatigue, malaise, irritability, low-grade fever, bony pain, joint swelling, effusion. Sign of marrow failure could be pallor, fatigue, bruising, oral mucosal bleeds, epistaxis. Signs of oral organ infiltration could be lymphadenopathy, hepatosplenomegaly, testicular enlargement. Signs of respiratory involvement can be seen if there is a mediastinal mass or enlarged nodes compressing the airways. Signs of CNS involvement are severe headache, seizures, papilloedema, retinal hemorrhages. ALL diagnostic criteria, CBC, peripheral smear, you will see atypical cells or malignant clones. Bone marrow morphology, more than 20% blast cells suggest ALL. Flow cytometry is for the confirmation of the diagnosis. CNS involvement in ALL can be done by CSF analysis. So based on that, the CNS has been divided into three categories. CNS1 is less than 5 WBCs per unit liter of CSF and no blast. CNS2 is less than 5 WBCs with blasts. Or in case of traumatic LP, the patient falls into CNS2 category. CNS3 is more than 5% blast, more than 5 WBCs with blast. The newer diagnostic tools that we have are molecular cytogenetics, FISH, karyotyping. Following are the common chromosomal abnormalities in ALL patient, its prognosis and incidence. Most commonly, we see the incidence is 20 to 25%, is hyperdiploidy, trisomies 4, 10, 17. They have got favorable prognosis. If you see a few mutations like T1221, they are also have favorable prognosis. T119, T411, T922, Philadelphia chromosome positivity, and infantile ALL with 11q23 positivity, they have unfavorable prognosis. This is the ALL ICBFM 2002 chemo protocol. As you can see here, there are the 3 rows, and for this study, the newly diagnosed ALL cases have been stratified into 3 risk criteria. The standard risk population are the patient who are newly diagnosed, which shows prednisolone good response. They fall into the age category of between 1 to 6 years of age. Their WBC count at the time of presentation was less than 20 into 10 to the power 9 per liter, and their M1 marrow, that is day 33 marrow, was favorable. Intermediate risk patients had prednisolone good response, age less than 1 or more than 6 years, WBCs more than or equal to 20 into 10 to the power 9 per liter, M1 marrow on day 33. High risk patients had poor prednisolone response, means on day 8 there was no complete remission. Day 33 marrow was not in remission. Some chromosomal abnormalities like BCR-ABL, T922, 411, MML, AF4 positivity, or the most important criteria is MRD positivity on day 78. That is the minimal residual disease after 78 days of intensive chemo, which shows the patient fall into a high risk category. In this slide, I have simplified the ALL ICBFM 2002 protocol. First is induction A, which is 4 drugs induction: prednisolone, vincristine, daunorubicin, L-asparginase, and intrathecal methotrexate. In induction B, we give oral 6 mercaptopurines, citrabine, cyclophosphamide, and IT-methotrexate. Next is consolidation. For intermediate and standard risk patient, we give methotrexate 2 gram per meter square. And in high risk patient, we give 5 gram per meter square. The dose is higher, along with 4 intrathecal methotrexate doses. Then we have reinduction first, which includes dexamethasone, vincristine, doxorubicin, and 2 IT-methotrexate. Reconsolidation, which includes 6 MP citrabine, 2 doses of cyclophosphamide, and IT-methotrexate. After that, maintenance phase starts, which is for 2 years. Orally, 6 MP, 6 mercaptopurine, and weekly methotrexate is given. And intrathecal methotrexate is given every 3rd month. Cranial radiation, it was reserved only for CNS3 positive cases. So this is the demographic data which have been studied. 106 children with newly diagnosed ALL were evaluated in this study. 65% were male, 35% were female. Age was 62% patient fell into the 1 to 9 years of age. 38 were above 9 years. The WBC count below 20,000 was seen in 69% patients, and more than 20,000 in almost 31% patients. Immunophenotypically, B cell were more than means 88%, and T cell were 12%. Peripheral blood absolute blast count following prednisolone prophase means the prednisolone response that we have seen at day 8 of the therapy is less than 1. Favorable response in 92% patients, and more than 1 into 10 to the power 9 per liter in 8% of the patient. Day 33 marrow, in 93% patient, it was in complete remission. Only in 2% there was not in complete remission. Day 33 MRD was positive in 47% patients, and negative in 47% patient, and positive in 14%. Day 78 MRD, which is the most important diagnostic criteria here, depending on which we have stratified the patient in various risks. So it was negative in 52% patient, which is a favorable response, and positive in 8% patient. So 8% patient fell into the high risk category. Standard risk were 35%, intermediate risk out of total 100 patients. Standard risk patients were 35%, intermediate risk 45%, and high risk were only 20%. So causes of mortality is also given here. Sepsis in 8% patient, relapse in 5%, and others, and few lost to follow. So amongst these 106 patients, 30% were in intermediate risk. 88% were B cell ALL, and 12% were T cell ALL. Risk stratification, 35% in standard risk, 45% in intermediate risk, and 20% in high risk. Extramedullary disease, 4% of them had CNS involvement, which so we have given them intrathecal methotrexate, and no prophylactic cranial radiation was needed in this study. Only 1 patient had testicular involvement, which resolved after chemotherapy. And the common abnormalities which were seen in this population was hyperdiploidy and Philadelphia chromosome positivity. Also, RT-PCR in 71 out of 100 patients showed translocation T1221 BCR-ABL positive, T190, T119 translocation, T411 translocation. The MRD analysis on day 78 was done, and the cutoff was set to less than 0.01%. The lower limit is 0.002% of quantification. So on day 78, MRD negative cases were continued with the same standard protocols, but those who were MRD positive, they were considered for intensified therapy. Oral 6-MP and weekly methotrexate were given as per same as in standard risk and intermediate risk. The overall duration of the treatment is 104 weeks. MRD, that is a small number of cancer cells in body after treatment. On day 33, 93% achieved morphological remission. Only 2 had induction failure. On day 78, MRD positive patients were shifted to high risk block. They were given intense chemotherapy, and few of them were considered for hematopoietic stem cell transplant. The mortality in this complete group was 18%. It was higher in the high risk group. The causes were sepsis, relapse, pancreatitis, which is treatment related complications, we may say, pancreatitis, intracranial bleed, methotrexate toxicity, and one mortality was because of the graft versus host GVHD seen in transplantation. The overall survival rate in July 2023 was 82%. Out of the 100 patients, 7 had relapse, 5 within 18 months. Hematopoietic stem cell transplant was given in 7 patients, 5 in CR1 and 2 in CR2. CR1 means already in high-risk patients, and 2 stem cell transplant were given in relapse patients. There were 3 deaths because of GVHD and relapse. The survival rate, as I have stated, the disease-free survival was almost 80%, and overall survival rate was 82% in this study. This is a graph showing comparative studies of ALL BFM 90, 95, and 2002 protocols. The time and the overall survival rate has improved. The event-free survival rate from 1990 to 2007 with the protocols has increased from 75% to 83%. Overall survival rate has improved from 84% to 92%. Relapse-free survival has improved from 80 to 86% with ICBFM 2002 protocol. The limitations to this study was, it was a retrospective study. It was a small cohort based on only 100 patients and no high infection related mortality was on higher side, which could have been ignored. Conclusion. Following and delivering chemotherapy as per ICBFM 2002 protocol is feasible to achieve better results without any major change in the chemotherapy protocol. This looks like it is a very feasible and very useful chemotherapy protocol for the newly diagnosed ALL patients. Thank you.
Atish sir, your comments, please.
So, good evening, everyone. Am I audible? Yes.
Yes, you're audible, please.
Okay. So, thank you so much, Team MahaIP, for giving me an opportunity to be an expert on this topic. So, and thank you very much, Dr. Priyanka, for presenting a very crisp, journal or article review. So,
Thank you, sir.
because the audience is, I think most of the audience is practicing pediatrician, I would be giving some comments on what are the things to be looked for whenever we are dealing with a patient of ALL, rather than directly going into the protocol. So most importantly, what problems we are facing as a practicing pediatrician is like missing so many patients of acute lymphoblastic leukemia on regular, regular OPD basis. So there are 2-3 caveats or 2-3 important things what we should always keep it in mind, that whenever patients are presenting to us in the OPD with prolonged fever, and if there is don't always expect that patient will be having leukocytosis. Many times, even almost 10% of the patients present with borderline leukocyte count, always look at the differential count. If the patient is about 30 to 4 years of age and there is a lymphocytosis which is persistent for long and patient is having prolonged fever, suspect something fishy and always follow up with a CBC. Many such patients can be acute lymphoblastic leukemia. Actually, it is not very uncommon disease. It is like you have seen 1.38 per 1 lakh in our huge countries. It's a quite common disorder. So that is one important thing, important message regarding diagnosis of OPD ALL. So at least suspicion, because what happens, we know that whatever malignancy, if we pick it early, the outcomes are phenomenal. Particularly in ALL, as this journal, and it has been written by one of my friend, Dr. Vipin Khandelwal, he was the first author for this journal. So the outcomes you can see that ranging from 80 to 85% disease-free long-term survival, and that was just unimaginable 20 years back. So what has happened over a period of last 20 years? We have not changed our drugs. We have just learned from our mistakes, learned from the past, how to utilize these medications in a better way. How, like initially, we thought in acute lymphoblastic leukemia that if we give steroids and some few drugs, patients will respond. So, and that is a correct thing to observe also. If you give steroids, 1 month, you are MRD negative, 80 to 90%. From this journal also, almost 80% of the patients were MRD negative. But it doesn't mean that we have killed all the cells. So the concept of leukemia initiator cell, LIC concept, is very important in leukemia. So it originates from one cell. So we need to bear in mind that we need to finish that one cell remaining in the body. So that is why these protocols have been formulated with multiple, we all of us know, like tuberculosis, multiple drugs with multiple mechanisms of action. Similarly, in acute lymphoblastic leukemia, we use drugs which have different types of action at work at different stage of cell, dormant cells, fast dividing cells. So everywhere these drugs act, and that is how we combine the drugs. So coming to talking about induction chemotherapy, we know induction means it has to be intensive. First induction 1A and 1B. We need to finish things as fast as possible. Make the leukemia undetectable. So it is impossible for us to make undetectable. At least some part remains. So initially we used to think morphological remission. Morphological remission means looking at the slide, less than 5% blast. That is not enough. So the modern medicine has given us the good tools like minimal residual disease, nowadays called as measurable residual disease. So in that measurable residual disease, we can count from 1 in 1 lakh to 1 in 10 lakhs. So that single cell also we can count. And fortunately enough, as the MRD has come into picture, day 33 and day 78, the outcomes have been like improving, ever improving. And not only that, these are the older, this is a bit older protocol. And we nowadays, we follow ICBFM 2009 protocol where the MRD has been pushed up day 15. It is always important to see how the disease is responsive. Disease response is the most important risk stratification criteria, like good prednisone response, and to the first dose of chemotherapy on day 8, if the day 15 MRD is less than 10%, then patient will be salvaged on the standard or intermediate risk. But if it is more than 10% and day 33 MRD more than 0.01%, then we take it as intermediate risk. But if the MRD is on higher side, more than 10% and day 15 and more than 0.01 in day 33, we always repeat at day 78 and see, because the whatever is the genetics, whether it is low risk, like Dr. Priyanka told, hyperdiploidy, where the chromosome number in the blast is more than 46. So high hyperdiploidy, translocation 1221, that is TEL-ML, that is a low risk disease. And there are high risk diseases like Ph positive ALL, so-called high risk earlier, but with the advent of targeted drugs like dasatinib, imatinib, this Ph positive has come into a very good outcome disease, and subsequently that will be classified in the lower intermediate risk because we have the targeted drug available. So this, because of this availability of such drugs and the best modalities of diagnosis, outcomes have risen to the tune of 90 to 95%. So much so that now we want to decrease the intensity of chemotherapy. So ALL treatment is one of the milestone success story in the history of medicine, because we have reached up to 95%, and now we are looking back at our success and saying, can we decrease some chemotherapy? So the recent protocols that have come, if you compare to this protocol, that in the initial induction phase, rather than using 4 anthracyclines, which is one of the most toxic chemotherapy or most toxic drug in ALL protocol, can we decrease it further? And yes, that the question has been answered properly by 2 protocols, UK ALL and ICICL, our Indian own protocol. If there are standard risk, we can omit our the daunorubicin or any anthracycline from the induction protocol, and we can just go ahead with the 3 drug. But yes, BFM still sticks to, even the recent BFM protocol still sticks to the same protocol, but they have decreased in anthracycline by 2 doses in the initial phase, so that long-term cardiac effects are less. So this is the success story of acute lymphoblastic leukemia. Most of the things I think Dr. Priyanka has covered well. So the only thing, we should congratulate the author and team for such a good, this is comparable to the West. The only thing that we see here is a infection-related mortality, almost 8%. If you take out this infection-related mortality, which is very rare in the West, the outcomes would have been 90%. So here comes the role of supportive care. So ALLs can be managed very well, and the outcomes are absolutely phenomenal if we can give a good supportive care. Whatever protocol we use, whether we use BFM, ICICL or UKLL or COG, there are more or less same, maybe some protocol a bit intensive or some protocols being less intensive, but the outcomes are almost similar. So I think, we are reaching towards the goal of 95% in acute lymphoblastic leukemia. Maybe the next generation will again further, and we will not leave even that 5% patients of acute lymphoblastic leukemia to be cured, because the whatever patients nowadays relapse, so this 10% they can relapse or they can die of infections related mortality or something, some other therapy related mortality. So many good things have come, like therapy related mortality we can decrease with proper use of drugs. In supportive care has improved like anything with the use of a lot of different infections protocol or guidelines. And whatever 5% still remaining, that will be taken care of by the CAR-T therapy or CAR-T. So CAR-T therapy is one thing which has come. If patient is high risk, we usually give chemotherapy. There are some high risk patients which may need bone marrow transplantation, and in this case 7 patients needed bone marrow transplantation, and the outcomes of bone marrow transplantation also are very good. But there are some leukemias in like ETP ALL, early precursor T-ALL, or very low hypodiploid ALL. They are very high risk, resistant to these chemotherapies. For those diseases, we have, like if they relapse post-transplant, we can give CAR T therapy. CAR T therapy, I think many pediatricians may not know. CAR T is like your own T cells. T cells, we know when somebody develops leukemia, because our T cells, natural killer cells, are not working fine. They are not taking care of our leukemia cells or any malignant cells. So we can train these cells in a way that they can kill lymphoblast or whatever the cancer, not only blood cancer, it has been tried in many other tumors. And there are third-party T cells also, so somebody else T cells trained to kill. So their T cells trained to kill tumor. Basically, it's a CAR T. There are so many generations of CAR T therapy. 4 generations are available. We call them as truck. And the whatever remaining 5%, I think in future, we will be able to cure them. I think that will be enough. If somebody has some question, I am very happy to answer about acute lymphoblastic leukemia. Thank you very much once again, Team MahaIP, for giving us this opportunity to present and be the expert on this topic.
Yes, Wankhede sir.
Yeah, thank you, sir. Thank you for your very informative expert comments and very crispy presentation by Dr. Pawar. Now we are moving towards the end of this session. So I request, Madam, are there any questions in chat box?
No, not yet. And actually, we have crossed our time.
Right. So I request our IIP secretary, IIP Raigad secretary, Dr. Ajay Kohli, to give vote of thanks.
Sir, he was in emergency, and so we will have to do that on us.
Madam is there? Neha madam?
Neha ma'am is also not there. May I request our MahaIP President Ramakant Patil sir, because his comments are always there. If he is present, we request him to give his expert comments. Otherwise, go ahead with...
Ramakant sir is not there. Ramakant sir is not there.
Yeah. Sir, we go ahead with vote of thanks and then we will close.
Yeah.
So we immensely thank those delegates who have joined on YouTube and here directly. And we thank you for their presence. Still, we are having 71 attendees. That is the success of the topic. And for that, we thank our President-elect CIIP, Dr. Basavaraja, MahaIP President-elect, Dr. Ram Gopal sir, our Secretary General, Dr. Amol Pawar sir, present MahaIP President, Dr. Ramakant Patil sir, Raigad IIP President, Dr. Vikas More, our mentor and expert, Dr. Nimen Mohanty sir, our second expert, Dr. Atish sir, presenters, Dr. Prasanna as well as Dr. Priyanka Pawar, our backbone of all webinars, Dr. Neha Singh, and Mrs. Pallavi Dharmadhikari for giving technical support. Thank you very much.